All right, good evening. My name is Victoria Gershuni, and I will be your moderator tonight. We have the SSAT webinar on high yield topics for the ABSITE 2023. This is part 2 of a 2-part series. Our last part was in December, and that is available online if you'd like to go back and look at those slides and presentations for resources as well. This webinar is hosted by the SSAT Resident and Fellow Education Committee. And if you'd like to learn more about the committee or become a part of it, please feel free to reach out to us. So as I mentioned, my name is Victoria Gershuni. I am a brand new baby faculty member at the University of Pennsylvania. I am assistant professor, and I do bariatric and foregut surgery myself. If you'd like to find me, I'm on Twitter at @bgershunimd. I want to take a minute to talk to you all about SSAT membership. I think it's a fantastic organization to get involved in, especially as a trainee. It, in general, has very low registration fees, which, as we all know, can be cost prohibitive in certain societies, but you get a lot of benefit for being a member. Not only is it an amazing community that you can network with, but there's a lot of resources like this that help with your education and provide a platform for improving your practice. To become an active member, you just have to have your medical license and be board certified. To become a candidate member, you just need to be in an ACGME approved program or an equivalent. And then if you're a medical student, be in good standing, and we'd be happy to have all of you. As I mentioned, many member benefits, some of them being the Journal of Gastrointestinal Surgery, which is our journal JOGS. You can join many of your peers, not only in GI surgery and surgery in general, but also within medicine at Digestive Diseases Week, which is a fantastic opportunity. And then there are plenty of awards, grants, and scholarships and traveling fellowships that are available to members and provide really ample space for you to grow and expand that community. And leadership opportunities. All right, so all of that can be found online, ssat.com. You can look at the resident corner, lots more available there too, including quizzes that you can use to help study for this ABSITE exam. And then there's actually a neat series called Mentors of the Month, where you can just hear face-to-face interviews between mentees and their mentors about their life and their experience as surgeons. So it kind of adds the human side to surgery. Just so you all know, this is being recorded, and a copy of that recording, as well as the slides, will be available on the website. There will be an email that lets you know when that recording is available. And then you can also subscribe to our SSAT YouTube channel, where you can find this webinar as well as many others from the past. And then if you are on the go and prefer to listen, when you're driving or unable to look at a screen, we have SSAT Sound Bites, which is a great podcast. And it includes those Mentor of the Month, as well as journal clubs and other really great informative podcasts. So check that out. Our schedule tonight is very straightforward. We have an hour and a half to go over 3 different topics. Our first presenter is going to be Carla Bernardi. She is also a newly minted faculty member at UPMC. She's going to be discussing advanced GI, foregut, and bariatric surgery. After Carla, we're going to be moving on to Jeff Choi, who is going to be doing trauma and critical care. And then after that, we should be having our lecture from Dr. Alicia Elmore, who is a breast surgeon. So with that, I just want to thank everyone for their time and effort and all of the commitment that went into making this a possibility. I realize that the ABSITE is a scary time of year. Take a deep breath, realize that you guys have all the resources you need, and that you will do great. Just take your time to listen to the information and know that everything will be okay. In worst case scenario, you can always take it again next year. No, but there's plenty of resources, and I know you all will do well. I also want to thank the Resident and Fellow Education Committee, SSAT at large, Dr. Maria Altieri, who's our committee chair, and Dr. Z Van Dong, who Z was a moderator in the past, and he really laid the groundwork for how to do this well. And then, of course, Beverly Hendry, who really helps us make all of these things possible for you all and does the behind the scenes work. We really appreciate everything you do for us. So we will continue on with Dr. Bernardi. I'm going to stop sharing, and then she will take over.
Everyone, 1 second. Everybody sees my screen okay?
Yes.
Thank you, Victoria, for the introduction. Victoria and I became friends when we were interviewing for fellowship, and we have kept in touch. So it's great when you guys are going on those interviews. Just remember, some of these people will probably be lifelong friends. So, like she said, I am also a new attending at the University of Pittsburgh. And today I will be talking to you guys about bariatric surgery, and then we'll talk about foregut. So bariatric surgery, I'm sure a lot of you are now exposed to and see a lot of patients that have a history of bariatric surgery, because this is just becoming more and more popular in our population. And I just wanted to review the NIH criteria for metabolic surgery. And you need all 4 of these in order to qualify. So first is a BMI over 40 or a BMI over 35 with a coexisting comorbid condition linked to obesity. Some of these are things like obstructive sleep apnea, CAD, hypertension, type 2 diabetes. Patients also need to show a failure of non-surgical methods of weight reduction. They need to have absence of drug and alcohol abuse. And depending on what institution or what program the patient is being evaluated at, this might vary in length, the absence from either one of these substances. And then they have to show psychological stability. So they all will be evaluated by what is an adjustable gastric band. So this is a restrictive procedure. This is more going into a historic component, since not a lot of people are actually performing this procedure, but most of us will still see patients who had this done, and we will deal with some of the complications. And for the ABSITE, a lot of the times what they ask you about is complications that are associated with an adjustable gastric band. So on average, excess weight loss for patients is reported between 50 to 60%. Advantages of this procedure in particular is that it has a low morbidity and mortality compared to the other bariatric procedures that we were going to. Like I said, some of the things that we see a lot is problems and complications. One of the things that you might be asked about, or for you to kind of have in the back of your mind if you ever see one of these patients, are the complication of erosion. Those patients usually show up to the ER clinic with pain or a port site infection. So if you see them, start thinking that potentially could be an eroded band. The next thing that you might encounter would be slippage of the band. And this has to do, usually patients will come with a sudden intolerance of food or sudden reflux. Most of the times this can be diagnosed with just an x-ray, and you're looking at the angle of the band. So normal is between 4 to 48. So really less than 60 should be what you're going for. And if you have a patient that you suspect this is what's happening, the first thing you want to do is you want to remove the fluid. So there's a port that connects to the band and there's fluid around it. And the more fluid you put, the more restricted the patient is. So you remove the fluid, make sure it's completely decompressed, and see if this helps with some of their symptoms, and then potentially schedule them for a removal of the band. We're going to talk about a sleeve gastrectomy. This is the most commonly performed procedure in the United States for bariatric surgery currently. For this, patients have about 70% of their stomach is removed. And the sleeve is created, as you see in this picture, over a calibration device. Usually it's a bougie, but it can also be a scope. And patients on average, their excess weight loss for this procedure is about 50%. Major thing to make sure that we talk to our patients about after this procedure is that there is a risk for postoperative reflux. So if you have a patient that has poorly controlled reflux on multiple medications, a sleeve gastrectomy may not be the best option for them for weight loss surgery. Finally, when looking at resolution of comorbidities, this is inferior to a Roux-en-Y gastric bypass, which is what we're going to talk about next. But as you see a significant decrease or resolution in things like diabetes, hypertension, and dyslipidemia. And one of the main complications that you worry about with these patients after a sleeve is a leak. And this can be an early leak, or you can either see it months or weeks after surgery. Next is a Roux-en-Y gastric bypass. This one is both restrictive, but it's also malabsorptive. So as this is the second most commonly performed procedure for weight loss in the United States, This one has an excess weight loss of about 70 to 80%. And with this one, we do see some higher resolution of comorbidities. Again, things like diabetes, hypertension, dyslipidemia, but about 90% or greater of patients that undergo this procedure have complete resolution of their GERD. So patients that come in and have problems with GERD or they have uncontrolled type 2 diabetes, we do try to consult them that potentially this might be a better option for them. As things to be thinking about as far as complications, it can be internal hernia, marginal ulcer, leak, or nutritional deficiencies. The ABSITE likes to ask on nutritional deficiencies, and a lot of the times, some of these questions in the question stem will tell you that the patient had a gastric bypass, and then they're trying to see which nutritional deficiency they have. So, looking at that the day or two before your ABSITE is usually helpful just to see what signs and symptoms patients have from the different. Go into more detail with these complications in a little bit. Able to just kind of show you the things to worry about with the bariatric procedures, mostly the sleeve and the bypass. So early on, a lot of these patients are high risk patients because they have multiple comorbidities. So things to worry about are things like a PE, and they also can be at risk for rhabdomyolysis because of their weight, especially if they had a prolonged procedure. And then some of the things to worry about early on, which you'll hear about, is a leak, both staple line and an anastomotic leak. And this is usually first seen with tachycardia. So a lot of the times this will be the first sign for these patients. So when you're taking care of these patients, or if you get this in a question stem and a person is tachycardic after one of these procedures, that should always be. Then a little bit after surgery, a couple of weeks or so with the Roux-en-Y bypass and the sleeve, some of the things that you can see are cholelithiasis when they have rapid weight loss. And then some of them also have some food intolerance that is new. So with the Roux-en-Y, patients can come in with a marginal ulcer. Marginal ulcer is usually patients have epigastric pain. They may have some intolerance to food. They may also have some dysphagia. This is at the GE junction. And so the first line of treatment is usually medical treatment. So you start your patient on a PPI, potentially Carafate, and then plus or minus do an EGD to work this up and make sure that it really truly is an ulcer. There will be some lifestyle things such as smoking or even being around smokers, secondhand smoke, or NSAID use, so medication use. So we do tell these patients before surgery that they have to sustain from both of these things for the rest of their lives. Next would be an internal hernia. So this can occur at one of the mesenteric defects. And this is something, again, to kind of have a high suspicion for patients that have a history of a Roux-en-Y gastric bypass that come to the ER with either obstruction or have really with tachycardia. These are things that should be in the back of your head, and thing patients should be taken to the operating room sooner rather than later. Some of the with dumping syndrome, and this is due to rapid entering of carbohydrates into the small bowel. And when you are talking to your patient, it's important to see when this is happening to see exactly what is the cause of it. Early dumping syndrome is usually within the first 30 minutes or so after a meal. It's a hyperosmotic load and they get fluid shifts. So they get things like hypotension, diarrhea, and dizziness. And then late syndrome is usually due to high carbohydrates that then leads to high insulin and then a rebound. For these patients, a first line is usually lifestyle changes, things like smaller meals, more frequent avoiding sugary drinks or diets, and then potentially medical therapy. And then finally, like we were talking about, some of these patients can have nutritional deficiencies. Things that are common after the gastric bypasses are things like B12 deficiency, anemia, hypocalcemia. But again, I know in some of those review books, there's a little table. I would advise for you guys to look at that right before the week of the test and try to memorize. This I don't think will be on your test, but just in case that you see it in a question, or in case that you are encounter a patient that has had one of these procedures. So this is just showing you the anatomy of a biliopancreatic diversion with duodenal switch. That's on the left. And then on the right, we have the SATI. And you can see that the one on the left has 2 anastomoses versus the other one only has 1 single anastomosis, since there's a loop of valve that gets connected to. Now shifting gears a little bit to talk about foregut surgery. So this is talking a little bit about esophageal anatomy, because they do like to give you questions on anatomy. So remember that the esophagus does not have a serosa. The mucosa is mostly squamous epithelium, except for that distal 1 to 2 centimeters, which is the xeal. 2 muscular layers. You have an inner circular and an outer longitudinal. Muscle, and then the lower 2/3 is. Oh, I see. You can't hear me. Let me see if I can. Okay, if it happens again, it says that I'm cutting out. Let me know. I'm trying to put my microphone closer to me.
Carla, I can hear you now.
Okay. Next thing is blood supply of the esophagus. So cervical esophagus, the blood supply comes from the inferior thyroid arteries. Again, I've seen this question, and I believe I even saw it on my written boards. So these are things that they like to ask. Then the thoracic esophagus, you do have direct arteries from the aorta, but then you also have some branches from the inferior thyroid, the inferior phrenic, and the inferior intercostal. And then finally, the abdominal esophagus, you have your left gastric and your inferior phrenic arteries that are providing the blood supply. Okay, a little bit about esophageal motility disorders. So I have seen this on tests where they will show you a picture of a manometry test, and they will also give you a description. So I think right now, if you know the descriptions and are kind of familiar with the manometry test, you should be able to get your questions correct, but it would be worth maybe looking this up before the test just so you see what these different manometry tests look like. So the first thing to talk about is diffuse esophageal spasms. For these on manometry, you see strong, non-peristaltic, unorganized contractions, and then your LES does relax. Then for nutcracker's esophagus, you see high amplitude, peristaltic contractions, also LES relaxation. This, on the other hand, when you're talking about achalasia, you see increased LES pressure, incomplete LES relaxation, and no peristalsis. And achalasia can then be further divided into 3 different types. I think that probably is a little bit advanced, but just know that there are more than one type of achalasia. And then for these esophageal motility disorders, the treatment first line is usually dilation. However, this has a high failure rate, but most patients, by the time they come and see you, they have been dilated by one of their RGI colleagues. You also can do medical treatment with nitrates or calcium channel blockers. And then once patients fail this, or if the patient comes to you before these have been tried, one of the things that you can offer them is a Heller myotomy. So a Heller myotomy, remember how we talked about that you have 2 layers of muscle? You go and you actually cut both of those layers, leaving only the mucosa. And this doesn't show, just so you guys know, you want to have about 6 centimeters of the myotomy on the esophagus and 2 to 3 centimeters on the stomach. So a complete myotomy will have some portion on the stomach as well. And then after this, you will do a fundoplication. Some people do a door fundoplication, which I will explain in a little bit, or they do a toupee. It depends on the reason why you're doing it, if you had any complications, and then also a little bit of surgeon preference. Next thing to talk about is GERD, gastroesophageal reflux disease. So this is very common in our population. It's due to increased acid exposure to the esophagus. Most of the times patients are treated only medically and they have some lifestyle changes. Things like avoiding the trigger food, making sure that they're standing up or sitting up after meals or not laying down, etc. They can also be started on a PPI. However, if you have a patient that is on a PPI and they do not have improvements, they should undergo an EGD for workup. And then if you have a patient that shows any of these symptoms, you should first line do an EGD because you're concerned for a potential malignancy. So things like dysphagia, adrenophagia, weight loss, anemia, or bleeding, this should be a little red flag that they need further workup. For GERD, some of the things to consider whether or not you should offer surgery to one of your patients. It would be things such as patients that are failing conservative management, medical management, there are multiple medications, and they do not want to be on lifelong PPI use. And so as long as patients have either one of these two things and they're a good surgical candidate, it is reasonable to talk to them about surgical intervention. Preoperatively, you want to make sure they get a manometry study because you don't want one of those motility disorders that we talked about. Imagine an esophagus that doesn't work already, and then on top of that, you put a wrap, like a stop at the end, is just going to give you a patient that's going to have problems with dysphagia and be very unhappy. And then another thing that you want to make sure before surgery is that you do an EGD. You can do pH testing or Bravo testing. This testing will give you a score called the Meester score, and a number for you to know is above 14.7 indicates reflux. So if your patient has that, then they have pathologic reflux. And then finally, you can get a barium swallow study to delineate your anatomy as well. During your repair, some of the things that are important to know and make sure that we accomplish, or key steps, are you want to try to restore the GE junction position, and you want to make sure that it's intra-abdominal, and you want to recreate your anti-reflux valve. So these can also be, sometimes patients can have this in a conjunction with a hiatal or paraesophageal hernia, which we'll talk about next. So you want to make sure that your hernia is reduced, that is completely intra-abdominal. You want to make sure that the sac is also reduced. You want to make sure that you do a high mediastinal dissection, because you want to make sure that the esophagus is easily mobile into the abdominal cavity. And you then close your cura. The use of mesh is controversial, so I don't think you'll get asked on that, but you could potentially use mesh for your closure. And then finally, you want to do a fundoplication. One of them could be something like a Nissen fundoplication. And for this, your wrap is about 2 centimeters in length, and they're done over a calibration device. A little bit about your types of fundoplication. So again, just to reiterate, you want to check a manometry study before you offer a patient something like a Nissen fundoplication or a full wrap. And that's on the right-hand side, the top one. You do want to consider the age of the patient. So as patients age, they might have more dysmotility of their esophagus. And so usually patients that are really in their 80s or around that age, we try to not give them a Nissen fundoplication because you don't want to make their dysphagia potentially worse. So a Nissen is a full wrap, 360 degrees. A door is 180. And then a toupee is a posterior 270 wrap. And here are examples of them. Okay. The next thing that can be associated with GERD and that you can have to make sure that you address during your surgery is a hiatal hernia or a paraesophageal hernia. So on the left side, we see the normal esophagus, and you see that the lower esophageal sphincter, it's intra-abdominally. And that's what you want to try to make sure that when you do your repair, that you're getting back to this normal anatomy. So we have 4 different types. The first one is a sliding hernia. Your GE junction is actually in the chest, and part of the stomach is also herniated. Your type 2, you have your GE junction intra-abdominally, and you have, however, you have a big defect. And so part of your fundus or your stomach has now herniated into the chest. Type 3, you have both things herniated. You have your GE junction in the chest as well as partial part of your stomach herniated. And finally, type 4 has some other organ. It can be stomach, it can be colon. Sometimes you can find things like pancreas, spleen, and all kinds of things that have herniated. With type 4 hernias, one of the things that we have to make sure that we look at, especially if you have this coming into the emergency department as an acute finding, is volvulus. And we'll talk about volvulus next. Okay, so elective repair is for all patients who are symptomatic. And then for patients that are not symptomatic, they're not always indicated. So you got to look at the patient's age and surgical risk and comorbid conditions. This is the volvulus that I was telling you guys, seen with a type 4. Organoaxial is more common. When patients present with this, they usually need surgery. However, if the patient is too sick, you might need to do an endoscopic decompression and a PEG tube. And this is just saying that if it's acute, you might be able to stabilize them, do decompression first, and then do this in a semi-elective manner. Most patients do not need to go emergently to the OR unless there's acute ischemia or there's some kind of perforation. This is the last thing I wanted to cover. There's a lot on this, but this is also something they like to ask about is gastric ulcers. So type 1, lesser curve, body of the stomach. Type 2, lesser curve and duodenum. This is acid secretion, high acid secretion. That's what causes them. And then type 3 is prepyloric, also high acid secretion. Type 4, lesser curve along the cardia. And then finally, type 5 is anywhere and is usually related to NSAID use. I think I went a little bit over time, so I wanted to give you guys that image preview, but we can share this with you guys later. So I'll stop here for any questions.
Great, thank you so much. And those look like some awesome image reviews. Very, neat images you have. So that'll be a great resource that you guys can all find on ssat.com webinar Residence Corner, where these webinars are stored. And then next up, we have Dr. Jeff Choi. He is a resident at Stanford, and he will be presenting today on trauma, which is another very dense topic and frequently tested topic. So we hope you get a lot out of this, and feel free as they're talking to enter questions into the Q&A, and we can always answer those either at the end of each section or at the end of the webinar as a whole. All right, thank you, Jeff. Take it away.
All right, thanks so much for the introduction. Hi, everyone. So today I'll be going over trauma and critical care. A lot of topics tested on the ABSITE. This won't be going to the nitty-gritty of things, but I try to kind of reflect back on the past couple of years after the ABSITE and really hit on the high yield points. So I hope after these 20 or 25 minutes, you'll be able to get some points on your ABSITE. So starting with the GCS, there's always at least one question on this. The general message I'll have for at least the trauma portion is try not to memorize and just use your logic and gut feeling that will usually get you the points. Not just make sure you review this because there will definitely be a question on the GCS. And just a reminder, the lowest GCS you can get is a 3. You can't have a GCS of 1 or 0. So just a reminder, just know your GCS. TBI is also tested often, and I've listed below, these are kind of the most recent guidelines from the National Brain Trauma Foundation. So I'll focus on what's recommended, specifically focus on parts that may be tested on the ABSITE. In terms of monitoring your ICPs or the intracranial pressures, the essential message you want to take away is anyone with a GCS of less than 9 with an abdominal CT, or if they still have a severe TBI, you want to monitor their ICPs. And there's two main ways to monitor it. You can either place a bolt or you can place an EVD. The difference is that with an EVD, you can actually drain the CSF fluid if there's elevated ICPs, but these are kind of the indications for monitoring ICPs. For severe TBI, you definitely want to monitor your cerebral perfusion pressure as well. And I'll be going over the formula in a second, but essentially it's your MAP minus the ICP. This formula might come up as well on the ABSITE. So MAP minus ICP is the CPP. You generally want to crank that up, at least over 60. And then the other important thing for TBI patients is that you want to start enteral nutrition ASAP, at least by post-day 5. I mentioned the not recommended points here because I don't think this will come up in the ABSITE. But I think things like prolonged prophylactic hyperventilation to drive the PaCO2s down, that used to come up, but that's really meant to be a temporary measure to bring down your ICPs. Hyperventilating for a long time is actually not recommended for traumatic brain injury. So here's the cerebral perfusion pressure formula I mentioned. And in general, your ICP goal is less than 22. It used to be 20, but the new guideline is less than 22. There's a lot of options that may come up on the ABSITE. You can give hypertonic saline, mannitol. You can paralyze patients. If needed, you can do a hemicranie. But the most important thing is to not resuscitate these patients with hypotonic fluids. So you want to give, NS. You don't want to give half NS or anything like that. And then this is always a common image question that comes up, differentiating subdural, epidural versus subarachnoid hemorrhage. These are just really helpful figures to really get an idea. If you look at the image in the bottom right corner, starting, we have on the left, we have the epidural hematoma, which, has a classic lens shape. The classic history will be patient has a lucid interval in the middle. And then this usually happens in kind of young, healthy adults after a big trauma. You get a tear in the middle meningeal artery, and you can see that because this is epidural, it's actually not going to cross the suture line. Contrast that with a subdural hematoma, which you can see in the middle image there. It's more of a concave picture, and the classic history will be, this will be an elderly patient who suffered ground level fall or an alcoholic, and this results due to tears in the bridging veins. And the difference is that because it's underneath the dura, it does cross the suture lines. On the far right there, you have a subarachnoid hemorrhage. I think the easy way to recognize this is that it kind of follows the contours of the brains, like the little, the squiggly contours of the brain. So that's usually a giveaway for a subarachnoid hemorrhage. You can see this in trauma, but you usually see this with aneurysmal ruptures as well. So, this is an easy question if you just familiarize yourself with kind of the history and the images. All right, facial trauma, I don't think it's a really high yield topic, except maybe knowing the Lefort classifications. I wouldn't go specifically into the details of memorizing how to manage each of these, but just keep this picture in mind about, essentially Lefort, 1, you start below and then you go up more cranially all the way towards the orbits, 1, 2, 3. Just memorize this picture and, you should be able to figure out if they ask you what Lefort fracture is based on the injury description. So I'd say this is the only kind of picture worth memorizing for facial trauma. All right, C-spine fractures. These questions do tend to come up, and I think probably the most tested are the C1 and C2 fractures. So just a brief anatomy reminder, C2, the axis essentially has like a dens that protrudes up, and your atlas kind of swings like a ring on top of it. The most common fracture you'll see for C1 for the ABSITE is a Jefferson fracture, where you essentially, you actually get a widening of the spinal cord. So you don't really worry about spinal cord, ischemia or anything like that. But this is a Jefferson fracture. Hangman's fracture, evident because this is kind of classically the fracture that happens when people are hanged to death. Essentially, there's multiple different types, and I don't think ABSITE will go into the nuances. The management depends on kind of the severity. It can be anything from rigid collar to operative management. Just know that Hangman's fracture is usually, it's in the articular processes, and you can do anything from rigid collar to surgery. The other type of C2 or axis fracture to know is the odontoid fracture. There's type 1, 2, and 3. Type 1 is kind of, at the tip of the dens. Type 2 kind of goes to the neck, and type 3 goes to the body of the dens. Long story short, I don't think they'll go into specifics of management, but this is just another CT odontoid fracture, is another common cervical spine fracture to be familiar with. All right, so moving on to neck trauma, this is, I've seen this question come up before on practice exams, et cetera. Zones 1, 2, and 3, and the way divided is by the cricoid cartilage and the angle of the mandible. And classically, they used to teach, depending on the zone, like different things you're supposed to do. But like I mentioned in the beginning, you want to kind of minimize the memorization you want to do for these trauma questions and kind of just trust your gut feeling and try to use common sense. Essentially, kind of regardless of the zones, patients you have to take to the OR for operative management. Essentially, if there's any question about airway compromise, if there's any, uncontrolled hemorrhage, if you think there's esophageal injury, you should probably head to the OR. If you think the story that's painted is, it's not as emergent, you can always do imaging, and usually that comprises CT angio of the neck, barium swallow. You can obviously do endoscopy, rigid or flexible, and bronchoscopy. But I think kind of they've probably gone away a little bit from going to the specifics of what you're supposed to do depending on the zone. It's mostly based on kind of what are the hard indications for operative management now. I think this can come up in terms of the details of how to gain access to neck trauma. I'll just put it here. I won't go through everything, but the most important thing to mention is that you should get a preoperative neurological exam. If you're putting in lines, you want to do it in the arm opposite side of the injury. You prep chest to the ears. This is a question that might come up is, how do you prep for trauma? Essentially, you prep widely. If it's isolated neck, you can prep from the ears down to the chest. If it's kind of everywhere else, generally the trauma principle is you prep from ears down towards the thighs, including the groins. And then in terms of incision, I think for the ABSITE, there's a couple different incisions you can use, but the main incision you can use is along the anterior border of the sternocleidomastoid, SCM. And the other part to know is to gain access to a carotid bifurcation, you need to divide the facial vein. And another question that might come up is, let's say you're doing your neck dissection and the patient suddenly becomes hypotensive and bradycardic. It's probably because you've stimulated the carotid body and you're getting the bradycardic reflex. So you just need to inject 1% lidocaine into the carotid body. And then in general, the principles of repair for vascular trauma, generally, most veins, vast majority of veins, it's okay to ligate, even, in, certain stances, like you can ligate the IVC as well. Things like that, I don't think will come up, but, if it's a question about neck vascular trauma, unilateral internal junglers, it's okay to ligate. You should at least try to spare the other side. External carotid artery, obviously it's okay to ligate. Internal carotid, you got to repair it. If you're doing a damage control surgery, you got to at least put in a temporary shunt. If all else fails and there's no other options, like you could ligate it, but there's about a 50% chance of a stroke. And the other principle to remember for any kind of vascular repair is if there's any concomitant injuries nearby, you usually want to protect the repair. In the neck, that's going to be using your strap muscles. And then the other thing is that if there's a carotid injury and if there's neurodeficits, you want to revascularize within 4 to 6 hours. Kind of beyond that, you can actually convert an ischemic stroke into a hemorrhagic stroke. So that time window might come up in some questions. And then these points, I think, are some pointers. I don't think will necessarily come up on the ABSITE, but essentially, this question might come up if, let's say, you're trying to repair the internal carotid artery and you see a hemorrhage kind of deep in the hole coming from the transverse processes of the cervical vertebra. The management is actually you just kind of stuff in some bone wax. And then for vascular injury, general principle is if you can't do a primary repair, you want to do a patch angioplasty, either with a vein graft or other grafts, or you can do an interposition graft. All right, so thoracic trauma, some anatomy to be familiar with. They might ask you what are the borders of the cardiac box. It's going to be the nipple lines, the clavicles, and the xiphoid process. The reason this is important is obviously, what's inside the box, the heart, the great vessels. So this might be an important border to know. Another kind of anatomic boundary to be familiar with is kind of the boundaries, quote unquote, for the thoracoabdominal injuries. This essentially is a line kind of below and a little bit lateral to the box. If you can imagine an imaginary horizontal line from the nipples going around to scapular tips and then down along the costal margins. If you have, especially penetrating an injury there very well could be a diaphragmatic injury. And if you don't repair those, people can get deadly diaphragmatic hernias later on and strangulate their intestines. So essentially, if you have, and it's more so on the left side because the right side is protected by the liver. If you have a thoracoabdominal injury, this comes up on the ABSITE, I would do at least a laparoscopy to rule out the diaphragmatic injury. And then, there might be a question on what are the indications for resuscitative thoracotomy. There's a couple different guidelines. I think the Western trauma guideline is probably the most quoted. There's also a set of guidelines from East. In general, blunt trauma, resuscitative thoracotomy, you only want to do if there's been CPR for less than 10 minutes. Penetrating trauma, we're a little bit more lenient. You can give up to 15 minutes. But actually, if it's like extremity trauma, you actually have a little bit of lower threshold. The general, I think, gestalt to understand is that resuscitative thoracotomy, especially in blunt trauma, it's unfortunately high chance that patients are not going to make it alive outside of the resuscitation area. And then just to highlight, when it says signs of life, those include things like pupillary reflex, electrical activity in the heart, respiratory efforts, so things like that. I don't think we have to go too much into the specifics about memorizing these different algorithms, but I think the general guideline I would have is blunt trauma. It's a little bit more stringent criteria. CPR less than 10 minutes. Some guidelines say they lose pulses in the trauma bay. Penetrating trauma, you can give up to 15 minutes or so. This is a question that could come up is, how do you gain exposure to kind of the different intrathoracic structures? There's kind of three main exposures you can get: median sternotomy, right and a left thoracotomy. Median sternotomy, obviously you'll get great access to the heart and the great vessels, and also including the left proximal left common carotid artery. Through the right, I think the general idea is that on the right side, actually, let's start with the left side, because when we do resuscitative thoracotomy, we'll go on the left. We do that obviously because it gives you much easier access to the descending thoracic aorta. So you're going to access that. You'll be able to see the left subclavian artery and the distal esophagus. The general kind of principle to know for esophagus is, starts left in the neck, and then right, and then back down towards the left, towards the diaphragmatic curse. So left, right, left. And so you'll see the distal esophagus with a left thoracotomy. And you can also see kind of distal left mainstem bronchus. On the right, on the other hand, you have, instead of the aorta, you're going to be able to see the SVC, the azygos vein. You'll see a vast majority of the esophagus through the right side, and most of kind of your airways, including the left proximal left mainstem bronchus. So I think, again, try to minimize your memorization and just kind of think logically. We do a resuscitative thoracotomy on the left side because we can access the aorta. You'll see the esophagus. You can see like the kind of the tip of the left mainstem bronchus. On the right side, you're going to see kind of the big veins and then most of the airway structures, including the proximal left mainstem. That's how I would memorize this part. All right. So moving on down into the abdomen. Let's say you do a Pringle maneuver and there's hepatic bleeding. There's only a couple places there can be hemorrhage from. It's either from the retrohepatic IVC or from the main hepatic veins. People talk about doing the Schrock shunt. I don't think that will necessarily come up in the ABSITE because there isn't that much evidence behind it. But the important thing to know is essentially, the general principle for hepatic trauma is you want to do good packing. You don't really need to worry about the quinode. The different segments, and that's for elective surgery, that's not for trauma. So you pack, and then to mobilize, you really need to do a subcostal incision. And I think for different organs, there's different WAST grade of injuries. I think the only two organs where this is really worth memorizing is for hepatic and splenic trauma. So let's start with hepatic. It goes from 1 to 5, and in general, to minimize your memorization, 1 and 5, I wouldn't pay too much attention to because they're most likely going to test you on differentiating 2, 3, and 4. So 1 is like you're not so much injured. 5 is if it sounds like really, really bad, just like shattered liver, your IVC and hepatic veins are ruptured. That's 5. So 2, just think hematomas and small lacs. And if you want to memorize kind of the specifics of what the cutoff is, this might get you 1 point. I probably wouldn't go after this one point, but 2, think about hematomas as small lacs. 3 are going to be bigger hematomas and lacs, and if there's a vessel injury with bleeding into the liver. Grade 4 is when you get bleeding outside the liver and there's kind of major parenchymal disruption. So this might be something worth memorizing if you have time. So in the pancreas, the general thing you have to know is that if there's no ductal injury, that's going to be grade 1 or 2, and it's usually conservative management. Grade 3 to 5, you say you treat like a crawfish, it fits in the head. You suck it, you drain it. If it's in the distal, you eat it. You do a distal pancreatectomy. And there have been studies looking at what's the role of routine splenectomy. Long story short, it's not going to be tested on the ABSITE because it's a little bit of conflicting evidence, and no guidelines have a specific recommendation on the role of routine splenectomy. All right, so spleen, obviously, question might come up on what organisms you need to vaccinate against. Here they are. The most common organism that's going to cause an ABSITE is a strep pneumo. And other than the liver, like I mentioned, this is probably the only other organ injury where I think it's worth, if you have time, memorizing WAC grade. Again, 1 and 5 probably won't be tested. 2, 3, and 4. Just the one thing to remember, if you're going to memorize the numbers, just think that the spleen is smaller than the liver, so the cutoff thresholds are going to be a little bit more stringent. So again, 2 is going to be the hematomas and small lacs. 3 is going to be the bigger hematomas and lacs, and 4, it really has to do with kind of vessel injury inside the spleen, or if there's greater than 25% devascularization. Right. So going to the bowel, a couple, I think, big pointers. If you get a question stem that talks about a chance fracture in the TNL spines, the other thing is that the thing to know is that these chance fractures are associated with concomitant bowel injuries. So that's just one thing to keep in mind. They're probably going to direct you to figure out to look for a bowel injury if they have a chance fracture in the question stem. Duodenal hematoma might come up. I think the kind of the classic keywords I'll say is like you see a stack of coins on your GI study. Generally, non-op management, NG tube, give them bowel rest, give them TPN for a couple of weeks, and it should resolve over time. And then with regards to the mesenteries, just a couple of principles. You don't want to cause any internal hernias. You want to close all the tears. If it's large or expanding, people say quote unquote 2 centimeter threshold, but it really depends on the question. I think they'll usually just give it to you. If it seems large and if it seems expanding, usually should explore it. And then obviously if there's any devitalized bowel, like bucket handle injury where the mesentery is, a big chunk of the mesentery is missing, you got to do the bowel resection. Retroperitoneal zones is a common question that comes up, zone 1, 2, and 3. I think there's, depending on what sources you have, they'll kind of give you different recommendations. This is the kind of the, in my head, this is the kind of the recommendation that I use. Essentially, if it's penetrating, explore it. For blunt, it kind of depends. Zone 1, you're going to have the great vessels, so you're going to explore. That's easy to remember. Zone 2, you have the, kidneys is the most important part. You're going to explore if it's expanding. And zone 3, it's going to be your pelvic vessels. Generally, like some people say, explore it, but generally there's going to be 2 main ways to address pelvic bleeding. Vast majority of the time, 70+% of the time, it's going to be venous bleeding. And you're actually, what you want to do for that is actually pre-peritoneal pelvic packing. So you actually don't want to violate the peritoneum. So you're going to make an incision below the umbilicus, stay on the pre-peritoneal space and pack like 3 laps on one side. So either do that if it's venous bleeding, or if it's arterial bleeding, you're going to ask IR to do angioembolization. So zone 3, I generally say, if you're doing laparotomy, don't explore it. Either do pre-peritoneal pelvic packing or send the patient down for angioembolization. GU trauma, I don't think it's as high yield, but can come up, and I think it's pretty easy point. I think the important thing to know is that for the blood supply, the kind of the upper 2/3 is going to be kind of coming from the medial, the lower 1/3 is going to be lateral. And when we say quote unquote, this upper and lower is the division between the proximal and the distal. It's usually kind of at where it crosses the pelvic rim is a simple way to remember it. Generally, if the defect is less than 2 centimeters, you can do a primary repair as long as there's no tension over a stent. It's if there's a sizable defect, with proximal, you can do essentially reimplant the ureter onto the other side. If it's more distal, you can try to reimplant into the bladder, And you can help this by doing a psoas pitch or a bari flap. Psoas hitch, long story short, you're essentially kind of bringing the bladder up and kind of hitching it up to the psoas muscle. Bari flap, you're taking essentially a flap of the bladder. I show a picture there, and you're trying to almost reconstruct the distal ureter. That's a bari flap. For bladder injury, it's a common question that can get asked. Essentially, if it's extraperitoneal, you just drain it, leave it in Foley for a couple of weeks. If there's intraperitoneal, you got to explore it either laparoscopically or through a laparotomy. The principle to remember is that you got to repair in 2 layers and you still place a Foley. So bladder injury, the important thing is to differentiate extraperitoneal and intraperitoneal injury. And then I think these are kind of 2 general important principles to have in mind when it comes to operative trauma questions. One is that if the question stem, points to a patient who is just really sick, acidotic, hypothermic, coagulopathic, they're really leaning towards you doing damage control surgery, which means just control the bleeding, control succus, and get out of the OR as soon as possible. So that damage control principle is something just to be on the lookout for operative trauma questions. And then the quote unquote 50% threshold, this applies to kind of your bowels, ducts. Usually the general consensus is that if there's less than 50% luminal damage, you can usually repair primarily. Other than that, you're worried about causing a stricture. So you need to do some sort of resection and reconstruction depending on what part of the body has luminal damage. So that's it for trauma. Well, let's do some quick hits on critical care. I think I got about 5-7 minutes. TEG is probably going to show up. I think it's a pretty high yield question. I think there's kind of 5 components to this. The thing I would just remember is you don't really need to memorize this graph. I would just remember the order. The first is going to be the R time, and then it's going to be the K time. But know that the K time and the alpha angle is talking about the same thing. And then the maximal amplitude and the LY30. I think it's helpful to know the details of exactly how this works rather than memorize it. But if you just want to memorize it, the simple way to memorize is what is the defect and probably what do you need to do. R time has to do with the initial kind of coagulation, the juices. So if there's an elevated R time, you want to give FFP. FFP has a lot of kind of our factors. K value and alpha angle is all talking about kind of fibrinogen. Fibrinogen is going to be found in your cryoprecipitate. So K value or alpha angle defects, you get fibrinogen. Maximal amplitude is kind of talking about the clot strength. It's really talking about your platelets. So for MA defects, you're going to give platelets. And then LY30 is really talking about the degradation breakdown. So this is where you're talking about TXA and anacar. So again, you don't need to memorize a graph, but I would just know essentially what product to give for defects in which part of kind of the TEG. In terms of addressing hemorrhage, the principle that you want to come up with is that you do allow for permissive hypotension. So you don't need to get these patients up to systolics of 120s, 90s, and even 80s is okay as long as they're mentating okay. Indication for TXA, tranexamic acid, might come up. Generally, you only want to give it if it's within the 3 hours of trauma. Some people say 8. I think most people will say within 3 hours. Reversal agents for common anticoagulants. I think this is a common topic that might come up. Essentially, for warfarin, you can get vitamin K. It takes a couple hours. So the faster thing to do is to give PCC, Kcentra. And then what's going to be in PCC? The mnemonic I memorized is 1972 CS. So it's going to be factors 10, 9, 7, 2, protein CNS. So 1972 PS is for PCC. For heparin, it's protamine. The bigatran is going to be Praxifund or itacitinib, and then all your XA sebans, Pixaban, rivaroxaban, that's your Eliquis, Xarelto. It's your PEM inhibitors. You can give Andexanet or PCC. And then this is one of those quick and dirty, easy memorization questions. I think you'll probably get a question on this on the classes of hemorrhagic shock. Unfortunately, this is one of the few questions that I think for trauma quick care where you actually do have to do some memorization. The only things I would remember is kind of what percent blood loss, which hemodynamic changes correspond to. Essentially, it goes in multiples of 15. And like most things, they're not probably going to test you on the extreme ends. They'll probably have you differentiate between class 2 and 3. So just know that if there is, if you start getting tachycardia, that's class 2, which corresponds to about 15 or 30% blood loss blood volume loss. If you start getting hypotension, that's going to be class 3, where you get 30 to 40%. And then, they're probably not going to test this, but if, patient has, acutely altered mental status and like no urine output, that's going to be class 4. But most likely I would focus on randomized differentiating class 2 and 3. It's going to be 15 to 30 and then 30 to 40% blood volume loss. In terms of product of resuscitation, we talked about this permissive hypotension, but I think the difference between FFP and cryo can be a little bit confusing. Just know that the easy way to remember is that cryo is made from FFP, and these are the factors that are there. Factors 13, 8 von Willebrand's factor, and fibrinogen. And I forgot where I saw this. I think I saw this on a YouTube channel, so I got to give them credit. But there's an easy way to remember what's in FFP. So look at the top. This is factor 13, no Roman numerals, right? And then just block out kind of the bottom half, like here, and then you get, if you just look at the top half, you get factor 8. And then imagine just connecting the 3 sticks, putting V's below that, you get von Willebrand's. And then, von Willebrand's factor, there's an F, so there's fibrinogen. So this is a little trick I use to remember what's in cryo. Hopefully this can be helpful. All right, precedent receptors, just wrapping up, I'll be done in 2 minutes. I think this is a very easy points to get if you just know it. Norepinephrine and levo, first line for septic shock. It's a little bit more alpha than beta. Vasopressin, probably won't be on it. Vasopressin receptors. Epinephrine, a little more beta than alpha. Kind of side effect to watch for is tachyarrhythmia. After a certain dose, you actually start getting more alpha. So if you want kind of inotropy, you actually want a little bit lower dose of epinephrine. Phenylephrine is going to be your pure alpha. Kind of side effect to watch for is reflex bradycardia. I think this might be a little bit too advanced to come up, but essentially, if it does, phenylephrine is great for patients with aortic stenosis. On the flip side, shouldn't use for patients with aortic regurg. Dopamine, this might come up kind of depending on the dose threshold. The receptors where it acts kind of changes. The way I memorize is actually like dopamine. It starts with the D, dopamine, and then the beta and the alpha, and the kind of quote unquote thresholds are 3 and 10 mics per kg per minute. The beta means beta and milrinone right there, phosphodiesterase inhibitors. So just know your pressors and receptors, because I think these are easy. Give me points. This I won't go into detail, but just memorize. You don't even have to memorize it. I think if you think through what's the primary cause, they'll give you like some marker of preload, whether it's the CVP or pulmonary capillary wedge pressure. They'll give you like cardiac output, the vascular resistance, and they'll ask you what's the underlying shock. Easiest thing to do is for all of these, just figure out what is the primary etiology, and then you should be able to logically work through the rest. So just make sure you can work through all these etiologies kind of on your own time. You shouldn't really have to memorize this. Propofol sometimes comes up. The important thing to note is that it has no analgesic properties. It depresses everything. Cardiac, CNS, respiratory is actually great for if you're having trouble decreasing your ICPs. The one thing that you want to come up that they might test for is propofol-related infusion syndrome. So if you see metabolic acidosis, profound cardiovascular collapse, that's PRIS. And I think I'm short on time, so let me try and get to the most, maybe I'll just end with this nutrition here. Just know, I won't go through this, but just know what the respiratory quotient is. Just know what the respiratory quotient is for the different kind of types of nutrition. Know the Harris-Benedict equation, what are the components of it. And the part you do have to memorize in terms of math is you have to know the caloric goal, especially for burn patients. And then you want to know the nutrition markers half-lives and maybe the nitrogen balance equation. So nutrition is where it's a little bit math heavy, but I think it's worth, if you dedicate 10 minutes to it, you should be able to knock out, I think, 2 or so points. So that's all I've got for trauma critical care. Hope that was helpful.
Great. Thank you so much. Again, very dense topic and a nice comprehensive review. You had a lot of images I've never seen before, which were really great too. And I think will help people, kind of commit this to their memory. So next up, we have our last presentation, and it's Dr. Alicia Elmore. She is a breast surgeon at the University of Pennsylvania. She is going to be going over the ever-present topic of breast surgery that becomes more and more complex as we get more and more advanced in the care of patients with breast disease. So I will give Leisha, you have the floor. Ideally, we're trying to finish by 7:30. And if anybody again has questions, especially as we talk about some of the changes in breast management, feel free to put them in the Q&A. All right, thank you.
Perfect. Good evening, everybody. Happy to take you home with a quick and dirty about breast. So over the next 25 minutes, we're going to spend about 5 minutes on anatomy, a couple minutes on breast imaging, 4 or 5 minutes on breast surgery basics, and then the bulk of the time looking at benign disease and breast cancer, thinking about, the questions you'll get on the ABSITE. So just to start, we're going to start with breast anatomy. So I've taken many ABSITEs and have seen questions about this, but basically the breast is made up, as most of you probably know, ducts and lobules, but the borders of the breast are kind of where I've seen questions. So superiorly bounded by the clavicle, medially by the lateral border of the sternum, inferiorly by the inframammary fold, and laterally by the latissimus dorsi. As you all know, it sits over top of our pectoralis major, and then beneath that is the pec minor, and that helps us define the levels of the axillary nerves. And so the anatomy of the axilla is one where I want to point out a few key points where I've seen some test questions over the years. And so to start, the boundaries of the axilla is the first place I want to start. So superiorly, the axillary vein, medially, your chest wall or serratus anterior, lateral, your latissimus dorsi, that's posterior and lateral. The intratrabecular groove of the humerus might pop up as an answer, which would also be reasonable for the lateral if that popped up for a question. Anteriorly bounded by the pec major and pec minor, and then posteriorly by the subscapularis. Other key points is, when we're doing an axillary lymph node dissection, for example, there are a couple key nerves that we're looking at, and injury to those I've seen present on test questions. So those two nerves are the long thoracic, which innervates the serratus. If that's injured, you get winged scapula. And then the thoracodorsal nerve, which innervates the latissimus dorsi. And if injured, patients will have difficulty with adduction or lifting that shoulder. There are also intercostal brachials, which are sensory nerves that run through the axilla. They have no motor function. Those provide sensation to the medial aspect of the arm. And so patients will complain of numbness if those are injured. And then another thing that I had to constantly study until I actually became a breast surgeon, the levels of the axillary nodes. So again, these are all defined by their relationship to the pec minor. So level 1 nodes are lateral and a little bit inferior to the pec minor. Level 2 nodes are posterior to the pec minor, and level 3 nodes are medial and superior to the pec minor. When you're doing any breast surgery, you're only going after level 1 and 2 nodes. If you're doing things like melanoma surgery, level 1, 2, and 3 dissections. So quickly to go over breast imaging. So there are 3 imaging modalities: ultrasound, quick, not hindered by breast density, mammogram, screening and diagnostic. So if someone has no complaints, you're getting a screening mammogram, but in the test setting, most patients will have a complaint. So that's going to be a diagnostic mammogram rather than a screening. And then patients who are under the age of 30 should be imaged with ultrasound for breast complaints on tests. If over the age of 30, both mammogram and ultrasound. The reason for that, you can see to the right, patients that are younger are more likely to be dense, and the mammogram is less helpful. And then MRI is an adjunct for high risk screening. So if someone's got a lifetime risk of breast cancer that's really elevated, lots of family members that have breast cancer diagnoses, or breast, ovarian, prostate, pancreatic cancer, those diseases you see together in BRCA mutations, which is also testable, then you would use MRI for high risk screening. MRI can also be an adjunct for extent of disease for breast cancer. And then BI-RADS is another one that comes up. That's basically what you'll get as an imaging. So I like to think of it in a few categories. If it's 0, you need more imaging. If it's 1 and 2, it's normal. If it's 3, repeat your imaging in 6 months. 4 or 5, biopsy it. 6, you already know it's a cancer. And so if you're biopsying anything in the breast, with the exception of a cyst, it should always be a core needle biopsy on test. So no FNAs of things, just cores. It can be done under any imaging modality based on how the lesion was best seen. And so breast surgery basics, that, just the quick and dirty of that. So looking at the SCORE curriculum, these are the key procedures that are testable. So I'm going to hit the high points of things to consider for each. As most of you know, two main categories for breast surgery: mastectomies and lumpectomies. Starting first with mastectomies, they come in a few different flavors. If we go to the left, total mastectomy means removal of all the breast tissue and associated skin, leaving people flat. Skin sparing mastectomy, removal of the nipple areolar complex, preservation of the skin envelope. Nipple sparing mastectomy, removal of the breast, leaving the skin envelope and nipple intact. Looking at partial mastectomies, those are a package deal with radiation. So partial mastectomy, also known as breast conservation, basically removing the cancer, a healthy rim of tissue around it. If it's palpable, then it can be removed without any special localization before surgery. If it is not palpable, then it would need to be localized, and that would happen with either a wire, or it's probably, I haven't seen this, but fair game for seeds placed to be able to find the tumor on the day of surgery. Reconstruction comes in a couple varieties. It can be done with tissue expander, which is effectively a balloon that inflates over time, or an autologous reconstruction. The most common type of reconstruction is the deep inferior epigastric perforator. And so this is basically a tummy tuck mixed with a breast reconstruction. The more important thing, how do you choose? And so in choosing the surgery, if you have a question about this, it's basically tumor size to breast volume is a large driver. So if you have a patient with a really large tumor and small breasts, then they're going to need a mastectomy. And tumor location, if it involves the skin in any way, most likely getting a mastectomy. Genetic mutation status, so if someone's got a BRCA mutation, high risk of a second cancer in the future, so reasonable to proceed with mastectomy and do a prophylactic mastectomy, as well as patient preference. So sentinel node biopsy. So for a sentinel node biopsy, basically it involves injection of two things, dual tracer, so a blue dye, most commonly methylene blue or isosulfan blue, either subareolar or peritumoral, does not make a difference which one. And then the isotope is technetium-99. And so that will drain into selected lymph nodes called sentinel nodes. Most patients have between 1 and 5. You remove anything that is blue or hot, and you're done when the remaining bed count is less than 10% of the hottest node, or any remaining nodes are less than 10% of the hottest node at completion. So now going through benign breast disease, I think this is probably the most high yield for ABSITE in terms of the questions I remember seeing. So we're going to kind of go through the quick and dirty, kind of hit the highlight terms that pop up in questions for all of the benign items that are in the SCORE curriculum. So high-risk breast lesions, the most common offenders are your atypical ductal hyperplasia, atypical lobular hyperplasia, or your lobular carcinoma in situ. And so why do we care about these? About 20% of women will have them at any point, but the reason we care is because they can be an indicator of a coexisting cancer that exists there, and they are markers of a significant increased risk of breast cancer in the future. So about a third of women will have an invasive breast cancer within 25 years. Risk of breast cancer is about 4 to 5 times higher in this group than average. And so if you get this lesion for the ABSITE, you cut them out. So excise them every single time with an excisional biopsy on the test. Other core findings, a radial scar. It's also known as a complex sclerosing lesion. I was surprised that this came up on my boards actually. But this is a stellate lesion with fibroelastic core are the buzzwords for that. Cut it out, excise it. Another one, flat epithelial atypia, completely benign, low risk of upgrade, no significant risk of breast cancer. You do not excise this. Intraductal papilloma. This is a classic question. This is going to be your patient that comes in with spontaneous bloody nipple discharge. And so this is a monotonous array of papillary cells. You work it up as you would any other lesion, diagnostic mammogram, and ultrasound. If there are no findings, then you proceed to MRI. And in terms of if they show you imaging, as you can see on the right, it's typically an enlarged duct with a filling defect. And the management of that on the ABSITE is to excise the papilloma. That can be done with a directed duct excision if there is a lesion, or a central duct excision, meaning removal of all of the ducts if there is bloody nipple discharge without a clear, or if you're not able to identify the single duct. Other low risk breast findings, fibroadenoma. This will present typically with a painless breast mass, typically in somebody that's younger. You would work it up. If they're super young, you'd get under the age of 30, you'd get an ultrasound alone, older mammogram and ultrasound. On ultrasound, it'll show up as a hypoechoic mass with well-defined borders. You excise it if it's big, so greater than 3 centimeters, or if it's enlarging over time. Why do we care? The reason we care is because we want to rule out Phyllodes tumor. Breast cysts. Another common presentation for these are asymptomatic masses. Most commonly in the test setting, what you'll get is someone that has straw-colored discharge. This is a buzzword for fibrocystic disease. These patients will typically present with a painless mass that gets bigger or smaller over time. It gets bigger and smaller with their cycle. And so if it's a simple cyst, meaning there is no solid component, there's no increased risk of breast cancer, it's totally okay to observe it. If it has a solid component, then it needs to be sampled or biopsied. And then based on those results, that's how it would be treated going forward. Fat necrosis is another one that may pop up. And so this typically presents in a patient with a history of trauma. And so, this is the person who was playing soccer and got elbowed in the breast. And then now they're noticing a mass. And on mammogram, it appears as a mass with a calcified rim. So this is a classic appearance of fat necrosis on imaging. Next, if any of you have rotated in the emergency department, this is really the only thing you will see coming through from the breast service. But mastitis or abscess. Mastitis is effectively, it's cellulitis of the breast, can be an abscess precursor and inflammation without underlying fluid collection. The important thing for this is if someone has gotten antibiotics and it is not improving, it's important to consider inflammatory breast cancer and proceed with imaging and biopsy. For an abscess, the big thing for those, we are no longer INDing, you aspirate them, rare indication to do an IND. The most common offender is Staph aureus, treated with a mild infection, Keflex, more severe, Bactrim or clindamycin. And then another test zebra is Mondor disease. This is a superficial thrombophlebitis of the breast. It presents as a palpable cord. It can be painful and have swelling. It's usually provoked as well after surgery or biopsy or trauma. As with thrombophlebitis and other parts of the body, it's self-limited. It'll resolve in about 4 to 6 weeks. So it's treated with just warm compresses and NSAIDs. And so now wrapping up for the last, 8 minutes or so with breast cancer. So moving on to breast cancer, SCORE wants you to know a few different things about breast cancer, and we'll go through those really quickly. And so as most of you know, 2 main subtypes of breast cancer, the vast majority will arise in the ducts and be invasive ductal carcinoma. They typically present either as asymmetry on mammograms, calcifications on mammograms, or a mass on clinical breast exam. And then there's invasive lobular carcinoma, which usually presents, they can grow in sheets and can be mammographically occult and would be something that you would get an MRI for. And so this is something that when you get a biopsy, this is the first thing you're looking at is the histology of the breast cancer. And then the other thing you want to know are the biomarkers of the breast cancer. So the 3 biomarkers are the estrogen receptor, progesterone receptor, and then HER2, which is a protein that stimulates cancer cell growth. And so I like to think of breast cancer in 3 main buckets, which helps me frame how to treat it when questions come up. And so there's hormone receptor positive, meaning estrogen receptor positive, progesterone receptor positive, HER2 negative. There's triple negative breast cancer, meaning that ER, PR, and HER2 are all negative. And then there's HER2 positive breast cancer, which can be hormone receptor positive or negative, but the main point is that they're all HER2 positive. And so treatment modalities for surgery, we talked about those options, partial mastectomy versus a total mastectomy. The key thing is partial mastectomy is a package deal with radiation. Oncologic outcomes are equivalent between the 2 types of surgery. And then most patients will get a sentinel lymph node biopsy. If those lymph nodes are positive, you have to take them back for an axillary lymph node dissection. In terms of your margins, another thing to mention is that if someone has invasive breast cancer, the margins are negative if there is no tumor on ink. If they have DCIS, you want 2 millimeter margins. And so the other treatment modality is chemotherapy, and then finally radiation. And so in terms of chemotherapy, who gets it? It serves to either downstage the tumor to make them eligible for breast conservation for people that are motivated. And now it's also based on biology. It can be given in the neoadjuvant setting before surgery or adjuvant, meaning after surgery. And now we'll go quickly through who gets it. And so when you think about test questions, like there's a lot of nuance in breast cancer that's super confusing. And so I kind of like to think of it big picture, the early stage and then local regionally advanced disease. And so for early stage cancers, those are your small cancers, less than 2 centimeters, 2 or 3 centimeters. Lymph nodes are negative. And then advanced cancers, those that have lymph node involvement and are large, typically greater than 5 centimeters or so. And so if it's early stage disease, surgery is king. So they're always going to go to surgery first. If it's advanced disease, then they're going to get chemotherapy first, because the likelihood that, there's, microscopic disease involved elsewhere that we just can't see yet is much higher. Plus, we know there's survival advantage. So you get a patient that's got really big tumors or lymph nodes involved, give them chemo. If they're small, do surgery first. And then, and then when we talk about those 3 buckets of biomarkers, so hormone receptor positive, triple negative breast cancer, and HER2 positive breast cancer, those also guide how we treat patients. And so hormone receptor positive breast cancer is a little more complex, but chemo is often decided by an oncotype, which is sent on the surgical specimen. So that's genetic testing sent on the surgical specimen. That gives you a recurrence score, which determines whether chemotherapy will be recommended. In patients that are triple negative, meaning ER, PR, and HER2 negative, the vast majority of those patients will get chemotherapy. So if you have a question stem that mentions a triple negative patient, you're probably going to give them chemotherapy before you take them to surgery. And then finally, HER2 positive patients, a lot of those patients will also get chemotherapy. And so, I'm so sorry. For those patients, it's typically given in the neoadjuvant setting, and they're going to get HER2 directed therapy like trastuzumab or Herceptin adjuvantly for 1 year. Endocrine therapy is also something that should be given to hormone receptor positive patients. And so basically what that does is it prevents binding of estrogen to the cancer cells, thereby preventing tumor growth and decreasing risk of recurrence. If patients are premenopausal, they'll get tamoxifen, which is a selective estrogen receptor modulator. It's an antagonist on the breast and a little bit of an agonist on the ovaries, but there's a theoretical increased risk of ovarian cancer. And so that's something to keep in mind. And for postmenopausal women, aromatase inhibitors are used. Their ovaries are no longer functioning, thereby postmenopausal women will get aromatase inhibitors, which prevents aromatization peripherally, which is their predominant source of estrogen production. And so then who gets radiation? In terms of the quick and dirty, as again, anybody that has a partial mastectomy gets radiation as a package deal, at least on the test. And then post-mastectomy radiation is given to women that have node-positive disease, multifocal disease involving the skin or chest wall, or large volume disease. And then the big one is inflammatory breast cancer. And so moving on to inflammatory breast cancer, even though it only represents about 1% of all breast cancers, it represents like 75% of ABSITE test questions. I'm generous, well, maybe not that many, but we see it a lot. And so the picture to the right is something that you may see, but effectively it's those patients that come in with rapid onset warmth, erythema, peau d'orange look, which is that orange peel look of the breast. And so that is from dermal lymphatic invasion. So if you get those patients, you do the standard workup, but you also want to do a punch biopsy of their skin. And so the diagnostic criteria more specifically is a rapid onset of symptoms. All of these patients will have a history of 6 months or less. Usually the erythema occupies about a third of the breast. And then obviously you have to have confirmation of invasive disease. And so the management of this is the same for every single patient. They're going to get all 3 modalities. So they're going to get chemotherapy first. They're always going to get a modified radical mastectomy, which means removal of the breast, and an axillary lymph node dissection. And then they're going to get adjuvant radiation. They are not getting reconstruction at the time of surgery. So if you see an inflammatory breast cancer and a question about treatment, it's the same every single time. Paget's disease of the nipple. So this is the classic appearance of Paget's on the right. It's a scaly, raw, ulcerated lesion. You diagnose it by doing a full thickness punch biopsy. You'll typically see large cells with pale cytoplasm and prominent nuclei, as you can see in the photo there. The workup, it's important to remember that about 50% of these cases will actually have a co-occurring lesion in the breast. So even if you see this, don't forget to do mammogram, ultrasound, work up the breast finding, and consider MRI because of the high risk that there will also be an associated in breast finding. Treatment is either a central lumpectomy, or if based on if there's an in-breast finding, then they may need a mastectomy based on the associated in-breast cancer. And then if there's invasive disease identified, then they would also need axillary staging with a sentinel lymph node biopsy. And so that is all of breast cancer in about 25 minutes. So my email's here as well as my Twitter. Feel free to shoot me a message if you have any questions.
Thank you, Alicia. Or Dr. Elmore, that was fantastic. So much information in there, and you really touched on the highlights. So thank you for doing that. As we mentioned, we will have all of this online, but we do have one question, and that was geared towards the inflammatory breast cancer. Dr. Elmore, in the chat, it says, do you also give adjuvant chemotherapy for inflammatory breast cancer?
You do not. So all of it will be given in the neoadjuvant setting.
Great. All right. So if there are any other questions, we have a few more minutes. We could let's see, I think that we've closed that one. And if not, then feel free to reach out to our presenters. And you can always view this again to review online, either on YouTube, on our channel, on our website, or as I mentioned, on the podcast, SSAT Sound Bites, all of which are great places to find old ABSITE reviews, and the part 1 of this series is available there as well. And with that, I want to thank our presenters. Really fantastic content, and you guys covered broad topics that are very relevant for the ABSITE. So thank you all, and good luck this year.